Today's talk is ICU planning and designing in the Indian context. And most of my presentation is based on the guidelines that Indian Society of Critical Care Medicine devised and is placed on its website through a committee to suggest these guidelines to the members at large, and they are available free of cost. A lot of information is also derived from other manuals, including the manual on ICU designing by the Society of Critical Care Medicine. That was to acknowledge that. So, coming to the presentation, ICU, is highly sophisticated and specified area of any hospital. So, it should be specifically designed. It has to be specifically staffed, should be located strategically in any hospital. It should be furnished with particular aims and objectives to prevent disasters, easy movement, etc. And it has to be equipped, particularly what are you looking at to achieve. We have different levels of ICU in our country, level 1, level 2, level 3. And therefore, the equipmentation of such ICUs will depend what level we are looking at. It would have its own dedicated medical, nursing and allied staff, should not be subjected to rotation around the rest of the hospital's parts. It should operate with definite policies, protocols and procedures, should have its own quality control, education, training and research programs. And the most important out of all, as we might be thinking that it's a part of anesthesia or medicine, now it is well understood and accepted that no more critical care remains a part of anesthesia, medicine, surgery or any other part of this specialty. It belongs to every clinical specialty of medicine, therefore it belongs to all, as it belongs to anesthesia or internal medicine. So, this was IACCM constructed a committee. I had the pleasure of chairing that committee, and it worked out about 18 months and designed those guidelines, and these guidelines are present on the website of the society. How do we go about designing, planning, etc.? So the initial part is planning, paperwork, homework, room work, brainstorming. Team formation is the most important part. Who will constitute the team, who will plan and implement your plans, thought process. Budgeting is very important in Indian scenario. We must form a definite view what we are trying to achieve, how much time we should take in the implementation of our program, and budgeting, in Indian scenario particularly, budgeting may become a huge constraint in final outcome of the project. I have seen a number of ICUs initially being planned and the implementation process is started in a very excited manner. And as we go on, there are changes in the programs, there is a huge exacerbation of budgets, extension of time, and ultimately you are not able to achieve the whole thing, and there is a unending frustration. So budgeting and keeping the expenditure within the budget is very, very important. We should initially decide what level of ICU we are talking about. One hospital may just need one ICU, another huge hospital, a teaching hospital may need many number of ICUs, cardiac ICU, neuro ICU, obstetric ICU, trauma ICU. So we should look how many ICUs we are looking at, total number of beds for the whole number of ICUs, and for each ICU, design, future provisions, central nursing station planning, which is very important, equipment selection, support system recommendations, environmental planning. We'll take them one by one. Human resource development remains a very frustrating, challenging part of ICU planning and implementation. And as we look at the expansion of intensive care scenario in this country, we increasingly face this challenge of human resource, trained resource availability as the time goes on. Other provisions we must look at possible research, data collection, documentation, and record keeping. Now, team formation. Intensivist naturally becomes the leader of the team. In many organizations, for long times, intensivists may not be involved at all in implementation of the program at the planning stage. And when it comes to final shape, giving the final shape to the ICU, equipmentation of the ICU, there are huge gaps are left. So organizations, hospitals, managements are better advised to include intensivists, and I am of the opinion they should go a step forward to include a nurse, senior experienced nurse in the team of planners, because they have lots of ideas which they have come across during their career while working in ICUs, what problems they actually would face in managing the patients. A finance officer, architect, engineers, and other persons if they are relevant. Budgeting, I have talked, and for each bed, a minimum cost in India would be 20 lakhs per bed to a reasonable high-end up ICU bed would cost anywhere around 50 lakhs per bed. This does not include cost of land and building. Now, location, where should be located? It should be located in the proximity of emergency room, operating rooms, trauma ward, imaging, so that the transport is safe, easy and fast. Corridors, lift and ramps should be spacious enough. No thoroughfare can be allowed through the ICU. No other movements can be allowed through the ICU. There should be a single entry or exit point, but at the same time we should ensure there are emergency exits in times of disasters, so that we can take out our patients who are critically sick through an emergency exit if it is needed. How much space is needed for each bed? This is very important, and there were a lot of brainstorming regarding this point. We made a survey throughout the country, and there were a variable. We just asked how much space you have provided to your patient in your ICU. The answer varied from 80 square feet to maximum it went up to somewhere around 200 square feet. Now, recommendations are from 125 to 250 square feet. Additional 100 to 150% extra space must be left to accommodate nursing stations, storage, and patient movement area. Survey of ICUs in our country has shown an average area of 125 square feet. Less than 100 square feet cannot be acceptable in any case. For level 3 ICUs, bed area of more than 150 square feet should be mandatory. Ideally, it should go beyond 200 square feet per bed area. Space allocation per bed should find precedence over all other facility for the purpose of accreditation. Now, this is, how we view. This is the 3D view of a proposed 10-bedded ICU. If you have a look at the picture of the ICU, you have cubicles, you have a nursing station, you have storage areas, you have patients area, talking areas, discussion areas, movement areas, these demonstration areas, etc. Now, you can have partition by curtains, as you see on this right side slide, and you can have cubicle system. This is a matter of choice. There is no data which supports that one is better over the other. So you can plan according to your requirements, your culture, your budgets. The cubicle has its own advantages and disadvantages, provides some privacy, provides some isolation, additional isolation, but at the same time, if you need additional space for adjoining patient, even in case the one adjoining cubicle is not in use, you cannot utilize space for the adjacent patient. That flexibility is available when you partition these beds by curtains. Now, this is the architect's view, how this should go about. On either side of the bed, you should have 5 feet at least available on the right and the left. There should be a minimum space of about 5 feet beyond the feet of the patient, foot end of the patient, and ideally a 2 feet space should be left between the head end of the bed and the wall, head wall. This is to ensure that there is a possible free movement of a nurse or a doctor in times of need on the hind side of the bed, besides the head of the patient, so that he can perform intubation or any other procedure in times of need. And now this can be done by providing about 6-inch height wooden pad, wooden board, about 2 by 2 feet, where a nurse or doctor actually can stand comfortably and perform. And this will keep the bed, in a steady position while you want to do a procedure. Now you have in the right side lower picture, you can see there is a panel containing various outlets of compressed air, oxygen suction, and then you have a light. And so this is the architectural imagination and that pictorial putting things together, how a patient's bed should appear and how much space you should leave on all the 4 sides of the bed of patient in ICU. Now, this cubicle and this I have already shown. Now, height of the monitoring system is very important. There are a lot of data in literature showing that because of looking at greater height than what the height of the nursing staff or doctors usually would be, around 5.5 feet to 6 feet, there is a possibility of neck getting retracted or neck pain. These doctors, residents and nurses suffering from neck problems. Therefore, the level of the monitor should be at a comfortable height, and they keep the bed 2 feet away from the head wall, which I have already explained to you. Now, how to bring the lines, the compressed air, oxygen, and these suction lines, the monitor's line to the patient from the head wall. Now you can have a pendant system, you can have a head and panel. 2 approaches are usually practiced. In our country mostly we find that most of the hospitals, almost 80% ICUs have head and panel. We can have power columns or pendants, but if you want to have pendants, then you have to have a very, very strong ceiling wall, because the heavy weight of the pendant would require to be hanged from the hooks fixed in the ceiling wall, and the ceiling may give way in case it is not well made, it is not very strong. Each room should be designed to accommodate a portable bedside X-ray, ultrasound, other equipment such as ventilators and balloon pump. When you are finishing the job or doing a sample bedside formation, then you should put all the things together in one room and see if you can easily operate upon the patient. That will give you an idea whether we are providing for the right space for the patient. Now, you can see this is a panel. Now, on this side you have a power column. Now, these are the pendants in these particular set of patients. So you can choose your pendants are slightly costly, power columns are still costlier, but if you have a power column moving from the floor, it might make your floor and movement little clumsy, difficult. So probably, I'm not too sure, there are no much data, but practically the feedback and our understanding suggests that probably pendants are preferred over power columns, and probably the head and panel is preferred over even a pendant. This will save a lot of cost. But in case money is not a problem, you want to give a fashionable look to your ICU, probably pendant would be preferred. So each bed must be provided access, access to music. Alarm bell is a must, which should indicate both sound and light. Isolation, 10% of the ICU beds may be designated as isolation rooms. They have to be cubicles. They cannot be rooms partitioned by bed areas partitioned by these curtains. Now, central nursing station. Now, this is the nerve center of the ICU. This is the vibrating area of the ICU. It is the area where everything is put together, where nurses are sitting, residents are sitting, discussions are going on. They are relaxed also, they accumulate data also, they keep the patient tickets also, monitors also there, the central nursing monitor is also there, you have drugs there, and lots of disposables also there. So the maximum emphasis should be placed on designing and planning for the central nursing station. All monitors and patient must be observable from this station. Most ICUs use the central stations serving 6 to 12 beds arranged in L or U fashion. Some ICUs have unit ports of about 4 to 5 beds. Some ICUs even have one nursing station for 2-3 cubicles. But I think that's not practicable in a country like ours. Nurses assigned to the patient in port form a team, and ultimately they coordinate. Again, this is the 3D view of a nursing station. How a nursing station ideally designed would look like. It's a use area as a percentage part of the whole ICU, and should be able to look through the entire length and breadth of the room, of the hall, of the ICU, should be able to. This is another form of the ICU. You have closed area, though you have covered it by glasses all around, and you can peep through into the whole room. Now, see, another recommendation is the entry and exit point of the ICU at this nursing station should have a slope. The arrow is marked at a different area, should have come onto the right where slope is very clearly shown, so that there is easy movement of wheeled equipment. If we have stores behind, in this particular structure, we have stores behind the nursing station so that nurses can store the unutilized equipment like syringe pumps, infusion pumps, even ventilators and monitors into the safe area. So this should be ideally, we should have a ramp or slope going in and out of the nursing station. Now this is the list of the equipment. I don't need to discuss this. There is a huge list and unending list. Each ICU can prioritize what equipment, how much they want to, what are their priorities, requirements, level 1, level 2, level 3. So this is whole list of equipment from endotracheal tube to ventilators, RRTs, dialysis, and everything. But maximum emphasis should be put on the smallest thing. We may miss. We should have the all possible smallest thing in the ICU. Sometimes, if we do not have many ventilators, we have one less ventilator, it will do. But if we do not have enough endotracheal tubes, laryngoscopes, these glucometers, sometimes they become quite frustrating. So this is diagrammatic presentation of the bedside table or overbed table. Now this should again have a slope, should accommodate the bed-headed tickets and charts of the patient, can have multiple cupboards, and these cupboards may be designed in a manner, if you open them, probably they would lit automatically. These are available commercially. And on the side, you can have more room for storing records, X-rays, MRI, CDs of these patients. Now this is the diagrammatic representation of the hand wash area. There are 3 ports, 3 taps, one for hand wash, another for means cold water, another for hot water, and then we have soft water. They might be foot operated, they might be hand operated by a long handle. To have a mirror is a good idea, and should be very strategically located where movement is easily possible. People would not go to remote areas to wash hands. Don't expect doctors and nurses to go to a corner of the ICU and they would wash their hands every time you expect them to do so. They should be as close to the nursing station as possible, at the same time keeping in mind the hygienic parameters, hygienic problems, the environmental problems. But keeping this wash area within reach of doctors and nurses, and one can observe whether the resident has gone to the wash area and washed hands, is very, very important. Now level 1, is good for small nursing homes, district hospitals, usually 6-bedded, should be able to do CPR, ABG is desirable, should be able to ventilate for about 24 to 48 hours, should do a minimal level of non-invasive monitoring, at least SpO2, NIBP, ECG, safe transport should be provided. They should train their staff, nurses and doctors in courses like FCCS structured as it is structured, should have access to some blood bank, basic diagnostic backup should be available, microbiology is desirable. They should always have a handy, at least one referring book on critical care medicine. Level 2, all this, they can go up to 6 to 12 beds. They are applicable to larger hospitals other than teaching hospitals. Director should be a qualified intensivist. They should have multi-system life support. Invasive and non-invasive ventilation should be done. Invasive monitoring should be done. Long-term ventilation should be available. Transcutaneous pacing is required. Access to ABG, electrolytes, other routine diagnostic support is needed for 24 hours. Nurses and duty doctors should be trained in critical care. CT is a must. MRI is desirable. Protocol and policies must be observed. Research is recommended. Now level 3, all that we have talked about level 2, this can go up to 14 beds, 10 to 16 beds, but usually anything more than 14 is not recommended. Must be headed by an intensivist. It should be a closed unit. Protocols must be observed, and the most importantly, they must have a space of more than 150 square feet per bed. Ideally, 200 square feet per bed, but anything less than 125 square feet bed must not be accepted for them. Human resource, not less than one resident for any ICU. Postgraduate is preferred. One PG plus one MBBS resident for ICU of more than 10 beds. Different groups for different shift and rotations. Provision for offs and sudden offs or vacations. Nursing staff 1 for 1 in ventilated beds or multi-organ failure patients on multiple vasopressors and inotropes. And in no circumstances the ratio should be less than 2:3, 2 nurses for 3 such patients. A compromise on that leads to a very poor outcome in the ICUs. This has strong bearing on the patient outcome. As said, 1:2 to 1:3 nurse-patient ratio is acceptable in rest of the beds. Now this is, the architect's thought process, presentation, and you can see the distribution of beds. You have provision for everything. There is an outlet exit here in case of emergency. You have store, you have this study area, doctor's area, meeting with patients, you have cafeteria, etc., and long separating area. So storage, it has to be important. Then you can have several stores. A store, what is to be stored by the bedside, what is to be stored in the nursing station, then nursing stores, and then we have a remote central store. Now this is how you can store your fluids, medicines, disposables. This is one of the pictures from Indian ICUs only, and you see very well. This we thought is a wonderful idea of storing good quantity of fluids, medicines and disposables in a very systematic manner, disciplined manner. So at a first look you can pick up any fluid. You have racks for anus, you have rack for dextrose, you have rack for other fluids and all sorts of disposables. This goes a long way. Now air conditioning should be central, should not be split or windows. It should be power backed, and voltage stabilization is absolutely mandatory in our country because we are never confident of getting a constant voltage supply anywhere in the country. There should be a good to minimize dust, bacteria and vapor by ideal methods in vogue, which are being regularly updated. I will skip this slides. Lights, particularly ceiling, should be, because patients all the time is looking at the ceiling when he's awake. So the ceiling light should be such designs which are friendly to the patient, and there may be breaks in lighting and designing of the ceiling. Furniture and furnishing, the counters and furniture should be tough to withstand a lot of heavy use. Easy to clean and maintain should not be a problem in our country because we have a lot of hard stone available. Connection should be made of metal to metal fasteners. Cabinet quality wood construction should also be tough and strong. Surfaces for counters should be solid, non-porous and strain resistant. Fabric should be durable, color fast, flame proof and static resistant if possible. Bedside clocks, calendars and bulletins in boards help the conscious patient well oriented and in better moods. Providing patient with place to keep a few small things he likes or likes and may be religiously important to him go a long way. Floor, walls and ceilings. It is recommended in Indian scenario that we have at least up to the level of 6.5 feet tile structure so that they can be easily cleaned and not spoiled by various stains and damages.
So,
Yeah. Another 2 minutes. So, waste disposal, we must follow the guidelines as recommended by various pollution boards. Provide clean area, large area, adequate area, optimum number of chairs, sofas, etc. for patients' relatives who stay long times, overnight, for days together in areas around the ICU, and they are, under tremendous stress. There should be provision for cafe around the clock to meet their needs. SDU. This is the area where patient care level is intermediate between ICU and floors. It is usually located near the ICU complex or within the ICU complex. The staff is almost similar to the ICU culture, and some of the patients who are not very sick do not require invasive monitoring or ventilation or multiple vasopressors. They may be kept in ICUs who still require some little upgraded medical care than floors. So, concluding, the key issues are we must form a team, we must do a brainstorming. It is ideal to have intensivist as the leader. I do not rule out a possibility of nurse leading the team. A good nurse may make a good leader, but because intensivists may not be able to spare so much of time for brainstorming, talking to architects, financial people, etc., administrators. Now we must budget number of ICUs, levels, etc., which we have all talked about. And at the end, the most important area is the patient bed area. Ideally, should never be less than, because 5 feet on either side of the patient, 3 feet is the width of the bed, 13 bed width-wise, 6.5 feet is the bed length, then you must have at least 4-5 feet below the feet of the patient, and we must have 2 feet behind the head of the patient. So the total area becomes a bare minimum of 150 square feet. Anything less than that is not recommended, should not be accepted. If it is a new ICU, the intensivist, the intensive care nurse, they should usually put their foot down that we must have 150 square feet per area. Anything more than that is a bonus or a premium. Thank you very much.
thank you, sir.